Hello. Hi. Hello. Hello. I am Stephen Collins. I'm the CEO of Matter. For those of you who don't spend, lots of time here, we do three things here. We're a startup incubator, we are a nexus for the healthcare community, and we're a corporate innovation accelerator. So we work with about 200 healthcare startup companies. We have a suite of services and programs for them. We work with about 70 corporate and institutional partners on their innovation objectives. And we do lots of events to try to facilitate and advance key conversations related to health and healthcare, kind of like this one. So we will, I think, have a really interesting discussion. We have a fantastic panel of real experts in health equity, and we're producing this event with one of our partners, Healthcare Service Corporation, otherwise known as Blue Cross Blue Shield of Illinois, Texas, New Mexico, Oklahoma, and Montana. I would have gotten that. They have been a partner really since the beginning of Matter. They were the first insurance company we partnered with. We have a variety of programs and efforts with them, and we're really excited to be currently working on a challenge related to health equity. So any of you who have solutions that might be relevant for improving health equity, we have a current challenge. You can find more information about it on our website. Applications are due next week, so the 12th. So there's no time like the present. So Joel Farran, who I'm going to introduce in a second, is going to lead this discussion. We're going to be using Social QA as the platform for questions. So go to matter.socialqa.com at any point. You can type in your question. You can upvote other people's questions. And at a certain point in the discussion, Joel will turn to the iPad. That applies equally well to anybody online who is watching this. So Joel Farran, who is, most importantly, he's a board member of Matter. In addition to that, he spends a fair amount of his time at Healthcare Service Corporation as the Chief Brand Officer and Senior Vice President there. The company overall has about 15 million, or insures about 15 million people. They have about 20,000 employees, and they've, again, been really a terrific partner of ours. Joel will introduce our panel, but for the moment, please welcome Joel Farran.
So Stephen did so well. I'm wondering what I'm doing here. So I'd like to thank you all for being here today for this dialogue. Your personal and professional passions have really brought you here today, and really appreciate, thank you. Really appreciate you being here to discuss how we engage as a community on issues of health equity to improve the health of our communities. I'd like to thank Matter for hosting the event. Thank you, Stephen and team, and of course our panelists, who I'll introduce in a moment, who have dedicated their lives to improving those lives of members of our community. Stephen, I think, gave a good introduction of who I am. The only thing I would add is that earlier this year, Healthcare Service Corporation, or Blue Cross Blue Shield, announced an endeavor, Affordability Cures, to build on our legacy of investing in our communities. Healthcare Service Corporation is a customer-owned company. So rather than returning earnings to or giving dividends to shareholders, we return any earnings back into the system to improve the health of our members and to improve the overall capacity and capabilities within our communities. So Affordability Cures aims to find long-term solutions that address the root causes of what is an expensive healthcare system. And this includes working more closely with our community partners to improve those social factors that can influence health. I'd be remiss if I didn't also put a plug in for the challenge that Stephen mentioned. We're pleased to be partnering with Matter on that innovation challenge. I'm excited to have a panel of representatives here from various aspects or organizations within our industry, our city, and our communities. And these individuals give their expertise and passion every day to help improve health equity, as many of you do in your profession. So maybe we didn't orchestrate this, so maybe as I read off your bio, you could come up here and sit down. Does that work for you all? Okay, all right, okay. I do want to read this so that I make sure I don't miss anything here. So Dr. David Ansell is the Senior Vice President of Community Health Equity at Rush University, where he also serves as the Associate Provost for Community Affairs. He is spearheading Rush's strategy to improve community health and economic vitality on Chicago's West Side. He spent 17 years at Cook County Hospital, where he implemented one of the country's first breast cancer screening programs. He has authored 2 books, a critically acclaimed 2011 memoir on his experiences at Cook County Hospital, and a second book, The Death Gap: How Inequality Kills. He received his medical degree from SUNY Upstate Medical University and a master's in public health from the University of Illinois School of Public Health. So 2 of my alma maters, Rush and University of Illinois. So welcome, Dr. Ansell. Okay, Dr. Tom Fisher. Can I say Tom? Dr. Thomas Fisher. Tom Fisher, I know him as Tom, is an attending physician with a specialty in emergency medicine at the University of Chicago Pritzker School of Medicine. He served as a White House Fellow in the U.S. Department of Health and Human Services, where he led the development of the HHS Action Plan to reduce racial and ethnic health disparities, and held previous positions with Blue Cross Blue Shield of Illinois, proud to call him a colleague, and Next Level Health, a managed care community network for Illinois Medicaid. He has his medical degree from the University of Chicago and his master's in public health from Harvard University. Please welcome Tom Fisher. Next, Jessica Hager serves as the Manager of Community Health and Nutrition and External Engagement at Feeding America's Chicago office. In her role, she has developed and executed a national strategy focused on improving food security, dietary intake, and health outcomes through cross-sector partnerships, applied research, and hunger relief sector transformations. She received her Bachelor of Arts cum laude in Communications, Anthropology, and Spanish from Southwestern University, and a Master of Arts in Social Work Administration from the University of Chicago School of Social Service Administration. Please welcome Jessica Hager. And finally, James Williams is the Director of Diversity, Inclusion, and Equity at the University of Chicago Medical Center. He has had a 30-year career with the University of Chicago, serving in a variety of roles across supply chain and admissions. The Medical Center has received several accolades for its work providing culturally competent care to patients and a safe, inclusive environment for staff. Williams received his Bachelor of Arts and Masters of Arts from DePaul University. James Williams. So I thank you again for all our panelists. We will leave time for Q&A at the end of the dialogue here. So what we hope for you to walk away with here is, number one, an understanding or a level set of what we mean by health equity. And number two, I think where we all want to spend time is learnings and actions, things we can walk away with in terms of opportunities that we can all tackle together, as well as those challenges that we face. And then thirdly, just have some dialogue here at the end so we can get to some of the questions that might be on all of your minds. Let me start with a definition, because we all are probably here with different ideas or experience about what health equity is, or based on what our profession is, sort of our role in addressing health equity opportunities. So let me start with a working definition as a level set, and then I'm going to have the panelists react to that a little bit. And then we'll move on to actions and learnings, where I think we'd like to spend most of the time. So we'll spend about 8-9 minutes on sort of definitional context level setting. We'll move to learnings and actions, and then we'll move to the dialogue Q&A, so you can all react to some of what you've heard, and perhaps questions that you've brought here. You can bring those to the group. So let me posit Robert Wood Johnson's foundation's definition of health equity as follows. Health equity means that everyone has a fair and just opportunity to be healthier. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So with that as a working definition to start us off here, I'd like to start with a question to James. And some could be cynical about us sitting here at the Merchandise Mart, downtown Chicago, discussing matters of inequity and health, talking about opportunities within our community. You and I had a good conversation about what you described as asset-based community development and the need. These are my words now, not yours, so you can do it better than me here. But the need the need to partner and not be an agent who acts upon. And I think you had some really powerful learnings there. Could you say more about the importance of awareness and understanding and competencies required to engage on health equity based on your experience at U of C?
Sure, I'm happy to. Thanks, first of all, for this opportunity. What I can share is that the University of Chicago, like other institutions in an urban environment, there's a dynamic between the community and the university. And so a number of years ago, actually when Michelle Obama was at the university, we started to be intentional about changing that dynamic and really look at the community as having a breadth of assets. And so looking at an approach to building assets, asset-based community development, really trying to see the people, understand their strengths and resiliency, understand what the institutions that were already in the community, how they could be leveraged and worked with, as opposed to kind of research and then coming back within the ivory walls, but really kind of taking that approach that there are assets already in the community, we can partner with them, and that way we can be stronger from a number of places. One, just kind of identifying what the problem is. We think we know what it is, but you need to ask people, what are the real problems? How are they perceiving that? And then work with them, actually, to kind of design whatever intervention would be most helpful. And then additionally continue to work with them in terms of evaluating the effectiveness of interventions and the like. And so kind of keeping that quality circle, but making sure that people are engaged. The other thing, from a research perspective, having a community-based participatory research approach so that the individuals that are part of the process actually reap the benefits. They understand what the information is. It's shared with them, and they actually are much more involved in the ongoing process. So that approach is something we took very seriously and we're very intentional about in terms of how to engage the community to really help change the trajectory of health overall.
Excellent, thank you. I'm going to turn to Dr. Ansell, and as long as we're still working on the definition and sort of going deeper on level setting on what health equity is, I'm going to go back to that Robert Wood Johnson definition, which talked about removing obstacles, and it's kind of a broad term, removing obstacles. Dr. Ansell, in your writings and anytime you talk about structural barriers as an important dynamic. Could you share with us what you mean by structural barriers?
Yeah, first, thanks for having us all here today. Really appreciate it. I've been a doctor for 40 years on the west side of Chicago. And I know what you're thinking. He looks really good. Even if you're not thinking that, please think that. And actually, coming to Chicago 40 years ago as a young doctor and beginning to observe the health and lives through the eyes of my patients, it really led me to sort of a different analysis of health than I was taught in medical school. And I think that led me to get a public health degree and to think about it more. But I want to tell you how I got about this structural piece of this and how important it is, I believe, to get the words right. So I'm not that totally crazy about the Robert Wood Johnson definition because it has we talk about things like the lack of access to jobs as if it's on the side, that it's the person's problem. So I want to paint a different picture for you. It's the picture I took to the Rush board 2 years ago when I took over helping to think through our health equity strategy. So where we sit here, this neighborhood, life expectancy is 85. And if this were a country, it'd be ranked first in the world. Think Japan or Spain. And now I'm going to give you 2 directions to go. You go west, 7 stops on the blue line, or south, 7 stops on the red line. And life expectancy in Garfield Park or in Washington Park plummets to under 69. And when people think of what's the cause of death that's responsible for that life expectancy, 16-year gap, you ask yourself, when was the last time in the United States life expectancy was under 69? It was 1950. So we have 1950 life expectancies, literally 6 or 7 miles away. And when audiences start to think about what's the cause of that, they think of violence, because we hear all about gun violence. But I say it's structural violence. And it's structural violence because actually the number 1 and 2 causes of death are cancer and heart disease. Not to say violence isn't the problem, but it's not at the root cause of death. But even then, when we look at diseases themselves, so people are dying from heart disease, you have to say, well, what's the root cause of that? So you say poverty. So here's a fact about Chicago. In this neighborhood and some North Side neighborhoods since 1970, income has gone up more than 20%. There's a rim around this blue lining, I call it, the wealthier neighborhoods, the, say, white neighborhoods. There's a little rim around those neighborhoods, about 23% of the city, where income has neither gone up or down. And since 1970, 53% of the census tracts, largely the black and brown neighborhoods in the city, have seen income go significantly down. So poverty is something that's been imposed. So when we talk about the structural causes of this, it's important not just to say social determinants of health. I say social, structural, including economic and political determinants of health. And then it requires us to name the root cause. And so as the only white man in this group here, no, you are. So
I'm a little bit. I'm not quite white.
Okay, well, I'm going to own to
NQW.
I'm going to own into my privilege to name racism as a root cause of this. It's not the only root cause, but it's a particular root cause. And after the events of last weekend, we have to name the root cause of the racism or white supremacy. It's really important that we get the root cause right, not because just naming it makes it better, but if you don't get the root cause right, how could you ever get it better? And we've begun at our institution of having to say, naming racism as a root cause and the exploitation of these neighborhoods that have occurred over many, many years. I don't say the word disinvestment because disinvestment sounds like I didn't give my son an allowance today, I'm disinvesting in you. When actually what we did is take the wallet, take the money, and take the clothes in terms of the capital removal from these neighborhoods. Because if we get that right, we now walk towards what are the structural solutions, and we'll get into that a little bit more.
So thank you for your candor. I'd like to give Jessica and Tom an opportunity to react to the definition or anything that James or Dr. Ansell said. And Jessica or Tom, anything to add?
So for those who aren't familiar with Feeding America, we're the national organization that works with 200 food banks across the United States, including Puerto Rico and Washington, D.C., serving every county. There's 46 million individuals who are considered food insecure by USDA's definition. And so that is considered a social determinant of health. So as we think about, we can talk about this later, the intersection of food insecurity, nutrition, and health, it's important if we acknowledge or understand someone that is experiencing living with diabetes and the physician says, great, make sure you take this food, make sure you take this medicine. We know that individuals are making trade-offs between food and medication, food and other basic needs. So that's part of when we think about what is the solution to addressing social determinants of health and health inequities. That's kind of the lens that I come from today. So when I think about health inequity, I always think of that definition is always broadening. So it's not just Robert Wood Johnson's definition, but it's something that needs to be evolutionary in our thinking and understanding of how society, the structural inequalities, the racism that exists, and our role in playing with that. And to your point exactly, we can't do this work if we don't engage the voices and the lived experiences of individuals who are disenfranchised within this experience.
My experience is largely as a function of taking care of patients in the emergency department on the south side of Chicago for the past 20 years. While I've had the opportunity to see the lived experiences of individuals who are in deep segregation and impoverished, I've also been in the rooms like at HCSC and at the U.S. Department of Health and Human Services where the policies are created that both liberate and entrap my patients. And so my perspective comes from both ends, and I think that Dr. Ansell's overview that describes this as something systematic is, one, important, and two, something that we have to do. We can't do either of two poles. One, see this issue as so large that we cannot address it and just feel overwhelmed and cynical by the obstacles that we're confronting, because that breeds the level of cynicism that lets us just stand with the status quo. The other side of that, which I often see as well, is that, well, because this problem, there really is no problem around. I don't see these issues as something we can do anything about. I don't see these issues around me. The data is in dispute. Maybe it's something that's genetic, in fact, that is being manifest in the differences in health status and health outcome that we all see. And I think that's also a falsehood. In fact, this is something that we created and therefore we can solve. And in fact, genetics have nothing to do with the racial disparities that we see in health. In fact, race is not a biological item. It's a social item, right? There are biological differences between people, but those do not map onto the categories that we've created to define ourselves. And so without falling to one of the poles, there's a lot that people in this room can and have done in order to tackle these things. And I think that hopefully we'll get to further conversations about what each of us have done in our work and personal lives to address these issues.
And actually, that's a great segue. So give everyone here an opportunity to put their thumbprint on the definition and sort of set as a backdrop what we're talking about with health equity. I'm going to assume, for the sake of moving us along, we all are on near the same page about what that means. We selected you all to be on this panel, and we could have selected any number of people, including many of you out there today, because you're doing something today. You're taking action. The organizations you're with are taking action. I think we can talk about it for the next 45 minutes, but I think we'd all like to hear about your learnings, about what you're doing, what's working, what's not working, and have all of us leave here with a call to action as well. What can we all walk away with based on your learnings? So I'm going to move us to actions and learnings at this point. And I'm going to come back to you, James. You talk about this inside out, outside in approach, and really building the capability for an organization to act on the mission, to engage and on solving for some of the challenges we face. Could you talk a little bit more about that?
Sure. So, excuse me. I'm part of a part of the medical center called the Urban Health Initiative, and essentially that's our public face. It's kind of like public health portion of the University of Chicago Medicine. And in that role, to talk about the inside-outside, there's work that needs to be done inside the organization in order to build their level of cultural and linguistic competence. I often give the example of, we need to build the agility within our organization such that if an individual flies in on a private jet or walks in from a box in Washington Park or has no way to communicate based on the languages that we understand, that we're able to adapt and meet that particular patient and that family right where they are and figure out a way to communicate, build trust in a short period of time, and then hopefully transfer that trust into a therapeutic relationship. So those are kind of like the broad strokes of what we are trying to accomplish. So if we build that internal capability and also going back to my earlier points around building on the assets of the community, we can start to leverage the resources within the organization to impact the community right where they see needs from a health perspective, and then also really to kind of go upstream and think about what are transportation issues, what are educational or health literacy issues, what are behavioral change issues that are sometimes generational. So for example, if you come from a family that hasn't had access to care and they see access to care as the emergency department, and that's happened because their grandmother or their grandfather, that was just, they waited till a situation became acute, they went to the ER, they got fixed up, and then they went back. If you have those types of behaviors that are entrenched, you need to figure out what are the ways to help change those behaviors, and that's a big piece of work. And so, our inside-outside approach is to look at how to integrate equity as a practice within quality, within human resources, within patient experience, all across the organization, so it becomes just the way we do business. We look at whether or not there's differential impact in terms of how we outcomes for patients, in terms of how employees are engaged, because we're trying to build capability with employees, and in terms of what the makeup of the organization looks like top to bottom when you stratify and look at race and ethnicity from the president's level down to individuals' entry-level roles. And so we really try to take this comprehensive organizational change approach to build the capability to hopefully connect with the community in a way that will ultimately change outcomes long term.
Yeah, I like the idea of moving from discussing competencies to discussing capability, because it really is about building capabilities within organizations and within communities to drive real change. Reactions from anyone on the panel to what James said?
Yeah, I think the structural piece. So how I see our work is through the socio-ecological model, and so it's with the individual at the center for those who are familiar. And if we're looking at and thinking about behavior change, there's the individual, kind of the interpersonal relationship, community, and it broadens out to systems and norms. And when we think about behavior change and equity, to put the onus only on the individual is problematic. And so I love what you're saying about we're thinking about everything from HR. Who do we hire? Who are the faces and voices within the organization that have the power and influence to make those decisions? So at Feeding America, we've done a lot of work around even thinking about who's on our board. Historically, 35 years ago, this was an organization that said, hey, there's food going to waste. There are folks who are in need of food. Let's connect those dots. And so our board has been wonderful over the years, but it's great to see an acknowledgement that the voices and faces needed to change in order for our work to change, to address the racism that exists in our society, the inequalities that exist in our society, and that influences the way we think about doing our work, whether that's research, the way that we hire, et cetera. And ultimately, hopefully, the programs, the interventions are people-based, lived experience led. And so I echo exactly what you're saying, that that's the hard work, but that's the work that must be done for us to actually move the needle on what we're talking about today.
There are two parts of this that I also think are worthy of amplification. The first is the recognition. So for example, the anecdote of people who come to the emergency department because of a learned experience is the recognition that people are rational actors. They're taking advantage of the resources available to them and the time that's available to them. And rather than focusing on what they're doing right or wrong, understand what is the system in place that they're responding to. Is there actually an alternative that's rational based on their experiences? Is it one that gives them the services and resources that they need at that time? I think often we fall back on this notion, well, if we just educated people, they would do something differently. But when we compiled this action plan for HHS, we looked through hundreds of interventions. Those that were largely education-based rarely worked because knowledge deficit wasn't the problem. Right? The problem is we don't have a system that works for people. Right. And behavior change writ large is extremely challenging. Has anybody seen this television program called Super Nanny? It went off the air in like 2011, where like some bad kid would get a nanny in their house to try to make them good kids. And it did work actually, but it took 2 weeks of a nanny around the clock, teaching a child a new pattern of behavior, teaching the family a new way of interaction. That's what it takes for behavior change. It's not something you can do remotely or with an app. You've got to be there 24/7 for 2 weeks to get a change in somebody's behavior, and then it wasn't durable, right? So when we think about behavior change, this is not a low-touch intervention, right? This is something that requires both changing a system and a very high-touch intervention.
So stay on this thought for a second. So James Rush, we've sort of thought of this as an inside-outside strategy. But think about whose behavior needs to be changed. So if it's structural, we really believe that this is structural. I'm still obsessed about the events of this whole country and the voice we've given to racism and white supremacism and the events of last weekend. I mean, it's just so disturbing, I think, for all of us in the room. But those are words and actions that we hope we can get buried under the ground someday, but that's a different kind of work for us. There's the implicit, unconscious ways that we may interact with each other that lead to misunderstandings in our day-to-day interactions. But the behaviors we have to change to get this right are the hardwired institutional behaviors that replicate the historic injustices. And that's where we have to get extremely granular within our institution. So I always say narrative plus data plus action equals change. So we need to actually look how we're actually performing within our own institutions. So, you know, we live in a society where there's a widespread belief that a rising tide will raise all boats. And that narrative, which is a false narrative, works if you own the boat and you're in the boat. But it doesn't work if you're in the water or if the boat has holes or there are too many people in the boat. And what equity means is those who need more get more. But our institutions, actually all of our healthcare institutions in the city, probably with the exception of Cook County, practice segregation. And practice segregation by race and then practice segregation by insurance status. And we all have a history. So the thing that concerns, and not that I'm not concerned about racist, anti-Semitic, violent, hateful speech, I am. But the work of our institutions is to undo. So we have to disrupt this, but then we have to dismantle the systems that are in place. So the systems are HR, the systems are our training programs, our systems are our search firms, and that's the work of all of our institutions to be able to do that. Let me give you an example from Rush. So when we got into this work, part of the inside strategy was using our employees as a first community and getting the voice of our employees. Well, that was eye-opening. So it turns out, and I'm sure it's true at University of Chicago and many of the firms you work at, that if you're an entry-level employee at any of our institutions, you're likely not making a living wage. And what we found is you could work at Rush for 30 years as an environmental service worker, as a transporter, or something like that, and retire in poverty. It wasn't our intention that you should do it, but that was the fact. And by the way, those tend to be brown and black people, oftentimes women. We discovered that if you make under $18 an hour at our institution, about 20% of those individuals are taking money out of their pension. We have a very nice, fair pension system. Are taking money out of their pension for hardship, meaning evictions or rent. And so we required us to look inward at our own processes around advancing low-wage employees. Because if we don't get it right in our institutions, how are we going to get it right in those neighborhoods? This is one example of how we've got to dismantle well-meaning systems that perpetuate these historical injustices.
So I peeked over here at the iPad, and there's tons of questions coming in. So I'm going to call an audible and get us to questions here sooner than I said I would. But I'd like to give you each an opportunity to share one initiative. So put what we've talked about into practice. One action, initiative, or effort that really highlights an action you all took or your organization took that made a difference. So give you all a chance to spotlight something that your organization has done. I'll just open it up.
So, so one example that I can share is we've had an opportunity to pilot community health workers. So asthma is prevalent in our surrounding area. And we trained community health workers to go into the homes and to, not 24/7 super nanny, but to spend time with parents and parents and kids around how to control asthma and how to control the negative aspects of it, obviously. And in those pilots, we've been able to kind of eliminate waking up at night, eliminate missed days at school, and eliminate missed days of work. So, because if I'm the primary caretaker and my kid is sick, I might miss a day at school. And so we've been able to do that in asthma and in cardiac, and just really trying to make sure that we're meeting patients where they are and providing them with what's necessary, the families with what's necessary to help change some of those behaviors. Because I agree, behavior change is extremely difficult to do. There are other examples, but I just wanted to share that one.
So at Feeding America, we've been working around kind of breaking down the walls between the social service industry and healthcare industry. And so we did a randomized control study called Faith DM. And so it looked at what can food banks do with healthcare partners to address diet-related disease in the healthcare setting and the food bank setting. And so from that study, we found that individuals that were enrolled and engaged in the intervention, which considered availed them of a food box and a particular weekly cadence, as well as connection to a healthcare provider on a regular basis, one-on-one connection, again, not the nanny, but enough. And so from that, we found that food insecurity rates decreased. It was a short enough span that we weren't able to see the health outcomes that we were looking at, which was the A1C. But what we did find from that is that we've engaged in healthcare partnerships. A lot of physicians now, or providers, are doing a screen and intervene approach. So you screen, it's a 2-item validated screener. If an individual responds yes to either question, it's likely they're experiencing food insecurity. And at that point, a provider, as opposed to saying, you have diabetes, here's the food, here's the medication, go and enjoy and manage your disease on your own, there's an acknowledgement that there's a barrier there. And so to either refer to a food bank or food pantry, such as the Greater Chicago Food Depository here in Chicago. It could be that there's now food pantry on site within a lot of clinics. Access Community Health Network is doing that here in Chicago. Or here's some resources for SNAP application assistance. So again, it's building those partnerships together, breaking down the walls that have historically existed between the community and large for-profit or nonprofit institutions that exist in the communities, and how can we work together to solve the problems.
Can I add one piece? So thanks to the work that your team has done, we have 5 pantries in the areas in the hospital to address food insecurity, and we are piloting screening for them as well. What we found that was interesting is that not only, to Dr. Ansell's point, not only were patients and families food insecure or at risk for food insecurity, but actually some employees. And so that was not something that we expected. But it does kind of underscore that this is a larger problem.
You get 1 point in the world for identifying, can you hear me? Identifying the problem, and 100 points for fixing it.
Maybe a little higher.
I was saying you get 1 point in the world for identifying a problem and 100 points for fixing it. Just shows it's much easier to identify than fixing things. We looked at the life expectancy on the west side and did a lot of organizational introspection, looked at our programs and said, none of them are really designed to move the needle on outcomes. And yet we could identify a couple of things that we got involved with that actually really moved the needle. The Ruth Rothstein Core Center, public-private partnership with Cook County and Rush, created a center for folks with HIV disease 20 years ago. Its history. We consolidated this, brought all of the services together, really treated the social determinants that led to HIV, along with treating the disease. Remarkably successful. 1 of every 3 HIV/AIDS person in Chicago went through there in the face of the epidemic, and the outcomes have changed. What made them different? Partnerships. Not doing it alone. Partnership with the community. Respecting the voice of the community. And we've had a couple others like that, but we could largely say most of our programs were not designed to move a needle. So we decided to invite folks to the table and say, what could we do on the west side? All of our healthcare institutions now are the largest employers in their neighborhoods. It never used to be that way, but U of C is the largest employer south of Roosevelt Road in Chicago. Rush is the largest private employer on the west side of Chicago. We invited a group of healthcare institutions who usually don't sit around a table together. We have 6 around the table, plus a community partnership with community leaders, and created something called West Side United. Focus on the west side of Chicago, 500,000 people, bigger than Minneapolis and Cleveland, and asking ourselves, putting a big audacious aim out there, could we reduce this life expectancy gap by 50% by 2030, and what would we have to do? And we decided that we would all need to work together in 4 different areas. One is health and healthcare. So there's a small part of this that is health and healthcare, but if we just applied evidence to what we know, like your work with asthma, we could really make a difference. The other is economic vitality. What could we do as healthcare institutions to, off of our supply chain, to hire locally, create career pathways, purchase locally and develop businesses off of our supply chain, and invest locally and help with some of the social determinants of health, like housing and other things like that. And we call this Collaborative West Side United. I'll give you an example of something that we actually done with University of Chicago and Lurie, is we started 2 career pathways this year. That's not so easy to do in a hospital system. One of them was for a medical assistant pathway. I'm thinking, who really wants to be a medical assistant? But it's a pathway to become a nurse. We had 25 positions, 4 institutions, just to get it going, 300 applicants in a week. Shows you the latent demand for this, and they're going through as a cohort. But that's the opportunity here. But we started another one, which was a patient care technician pathway, all community members. So these are folks who are difficult to hire, want to get a foot in healthcare. We had 17 openings in 1,200 applicants. And this week I got to sit around and hear some of the stories. One of them is homeless. The other one got hit by a car. So when you think about the social determinants of health, there's social determinants that affect employment as well. But this is the work. This is very different work for healthcare institutions to do. And if we can scale it and we can do it across other industries as well, we can really make a difference in this city.
Tom?
You know, I'll focus mine more on workforce. I've had a lot of opportunity over the past, 8 years or 9 years working in insurance as an executive to align incentives, because you do get what you pay for. And so as long as you're paying for unequal care, that's what you'll get. But more importantly, I'm very interested in what does the workforce look like who's delivering care? And who are the executives in the room when these decisions are being made, and what are the experiences that they bring to bear when they're weighing some of these complex, nuanced decisions? What we've learned over time is that most decisions that are neutral will have race implications and equity implications unless they're considered a priority, right? And so this goes back to the rising tide lifting all boats. We know that is not the case. As a part of my clinical practice, I've had the opportunity to select and train about 15 or 18 years worth of residents. One of the challenges that we found is that we've always been in the mode of looking for Jackie Robinson, right? That woman, person of color, who is above all other peers, the best in every class, exceptional in every way, as the bar for acceptance and promotion. When in fact what we want is somebody who is good, which is what the bar of everybody else is. Mm-hmm. And when they're there, they should have the opportunity to fall within the bell-shaped curve. They don't have to be 2 standard deviations away from average in order to be accepted as a competent and contributing component of each class. And over the years, that took a lot of behavior change amongst decision makers to recognize that women and people of color and LGBT communities, physicians in particular, need to be represented in each and every room where care is being delivered and where decisions are being made in order to have a rational decision-making process. We now boast in emergency medicine. I don't vouch for all other specialties at the University of Chicago. We have one of the most diverse programs in the nation. And as a result of that, it's self-recruiting. Right? It took about 10 years of hard labor, where when you had somebody stumble, the issue was at first about, well, why do we have such a diverse program if they are stumbling, as opposed to recognition that in every class people stumble, right? You are allowed to be average, right? You're allowed to be okay. You're allowed to have family issues that impede you. You're allowed not to be a great test taker and still become a great physician. And so inculcating that into a culture is the only way in which you get past trying to be Branch Rickey and assume that everybody is going to be Jackie Robinson, and actually get to a real inclusive organization that respects people's views and understands where they're coming from and brings that to the table.
All right, I lied. I have one more question for each of you, and then we're going to go to the phones. Hearing all of you talk, and I didn't prep them for this question ahead of time, so hearing all you talk, just tremendous amount of passion and insights. Maybe you could share, just to make this personal for a moment, what's led you to where you are today, doing what you do today, speaking out, taking action. It'd be great for us to hear that. Maybe we could kind of put you on the spot.
Sure.
Maybe we'll just go down the row.
So I was born in Cook County Hospital, and at the time I lived in Inglewood, which, if you're not familiar, a lot of people are not trying to move to Inglewood now, but these are my roots. I lived in my early years on the southeast side of Chicago, and my parents used to, take me around, and I could see very clearly where there was massive resources and diversity of businesses and housing stock that looked robust, and my neighborhood, which did not look as robust. And so early on, I had a desire. I said, well, we need to build some things here. This can be better, because there wasn't a great difference between, my friends and people that I met. So I went to school at a prep school in New Jersey, where the socioeconomic strata was very different from where I lived. But there wasn't a big difference in what we as people wanted. We wanted safe, secure places. People want their families to thrive. They want to be able to, have their families thrive. And so I've always had a desire to do whatever it was that I could do to make whatever policy changes or structural changes or work within an organization to, as I call it, right inequities. We need to right inequities at all levels that we have an opportunity to do. So I take it as my personal challenge. I have a vested interest in the South Side of Chicago. So West Side Alive, we have a South Side Health Equity and Innovation collaboration. And these are the things that, that are near and dear to my heart, because I think that, people want to thrive. I don't want to be part of that solution.
Thank you.
So as many of you may know, in community organizing, it's all about one-on-ones and sharing each other's stories, and from that, kind of having an ability to empathize or understand stories beyond your own. So my mom immigrated to the United States from India, and I grew up I assume that you all think I'm white, and so I carry that privilege with me, and then the responsibility of what that holds. And so I grew up in an environment, though, my mom's culture was all about understanding people's story, telling stories, hospitality, being in community, and ensuring that we live for each other and move in that space together. And so that's just the environment I grew up in. My mom actually worked at a food bank as a fundraiser, as I was telling the other panelists earlier. And so that was great. She raised the money, and the money is necessary to get work done a lot of times. But as I was going through my own schooling, I realized what really got me out of bed in the morning was looking at the systemic issues in our society and what role I could play with others and with communities in being part of that. So when I started thinking about, I worked in a nonprofit great community problems there. And so my wife and I moved to Chicago, and I went to the University of Chicago for social work, and I always knew I could do this. People have amazing personality and parking skills that do that, but I knew it was not my thing. And so I went into learning about structural change. So I started working at Feeding America, and At the time when I started, they used to say, we are the largest charity. And I have personal issues with the word charity. And so I've been fortunate to be part of the organizational change over the last 7 years to start to see themselves as an organization that has a responsibility to address the systemic issues when it comes to food systems, but also
I will try to be concise. I grew up very middle class on the south side of Chicago, which gave me the opportunity to see how this city works very differently depending on who you are and who you're with, because I got to be exposed to both sides or multiple sides of our divide related to segregation, socioeconomic status, and race, and I got to see that very early on. And my mother is a school social worker, the CPS, and so she was very proactive about describing how this isn't an accident. Like, we did this. Society created all of these things that you see around us. None of it was accidental, and therefore you have the opportunity to change it, right? We are not a victim to this. We as a society can make things differently, and sort of I organized my career around that, and I think it remains important because I'm going to butcher this quote, but Nietzsche said, when you stare into the abyss stares back at you. You know, the things that we work on.
Spits at me.
Yeah. The things that we work on us, right? And so if we are only working on things that are self-aggrandizing or one cannot easily link them to the sort of change in the world, that's who you become, right? And so it's very important for me to be tangibly related to seeing the things that I want to see, because I know that impacts me.
Well, I'm so excited, so I'm going to just try to stay with Sergey and Mikhail as long as possible.
Yeah.
But I'll come in like maybe 5 minutes
Okay.
before.
That should be fine.
And
before my mom
I think
died.
Karuna said she's got all the handouts.
I have all the handouts.
Okay.
Yeah.
Awesome.
That's fine.
And are there anybody calling in?
Yeah, so we have a couple of, I think overall 15 people signed up. There are 10 expected in person and like 5 who are coming in virtually. So
Okay.
I'll also sit in the back and try to manage the conversation with them.
Thank you so
No,
much.
that's what I have to do.
Great.
We're going to mic you.
Walk through doors because of this was shocking to me, and to see these very systems in place to this day in this country. And as a young person deciding to go into medicine, and my epiphany in that first year of medical school was that health is a human right, and that I describe myself as a physician, an epidemiologist, but a human rights activist for my personal work. So what I do and where I do it is always about to advance human rights, and it does require we have to not allow the speaking to go on, this hateful speaking. But if we don't disrupt the systems that keep the same people in power, the same voices around the table, that's been my work, and there's a lot of work to do. And actually, we need all of your help and all of your organizations. So especially the white men in the room need to speak about this more directly. It took me many years to speak directly about racism. I talk about discrimination. I talk about everything except naming racism. Part of the reason I didn't name it when I had to sort of do my own root cause is I had benefited so much from systems that would just put me at the table and not others. And I do think we have an opportunity in this city, which is a Democratic-run city, so you can blame Springfield and Washington, D.C., but actually in Chicago, it's always been our problem to solve. And I do think we're at a moment of time where if we get enough people around this and really just speak honestly to it and put the systems in place. So this comes from my parents' immigration to this country.
Thank you all for sharing. Hearing you all actually reminded me of something I saw on Twitter. Someone had posted something, and I try and limit my time on Twitter these days, but
Smart man.
one thing I read really struck me and really resonated, and I thought about that as I heard from all you. And this individual, and I wish I remembered who it was so I could give them attribution. They said, in our country, American means white. Everyone else has a hyphen. And it really resonated for me, also as son of an immigrant who came here. But even though my dad came from a humble background, service was something. He worked 3 jobs so my mom could go to school, and service was something he delivered on every day. and either in his profession or on weekends volunteering, and that's made an impact on me. So as I promised, we're going to go to the phones. And actually, I love this first question because it was one I wanted to make sure we got to. And I'll ask the specific question here, but as context, I'd be remiss here at Matter if we didn't talk about the fourth industrial revolution and the role that technology and data plays in our lives and perhaps plays in the industry of health and healthcare. And when you think about the inequities and the gaps we've just talked about, there's also the risk of unintended consequences of those disparities getting even wider. So let me ask this first question here. Do you find, this moved, okay, all right. Can technology improve the availability of care and thus begin to influence behaviors, telemedicine, mobile clinics, et cetera? So there's a specific question here, but maybe more generally, how should we be thinking about the role of technology and data to address some of the opportunities and issues we've talked about?
Can I just give maybe 40,000 feet and then step back?
Please.
There are certainly some technology interventions that extend the reach of the healthcare setting to people who previously have very high obstacles to its acquisition. So for example, people in rural, telemedicine is very helpful for certain people in rural environments. It's quite helpful for mental health. It has not been demonstrated to do much in other ways unless it is connecting a provider to their patients as opposed to just random providers to random patients in general. I think that there is a real challenge around social media with data. I think that what we've demonstrated from the last election and from what's happening around the world is that what is most engaging is what pushes us apart. And I think that we've seen the algorithms without any human touch amplifying messages that are quite divisive into people's echo chambers and have divided us. And we've seen some very polarizing elections around the world and including in this country, which I think are challenging. I think in ways that data can be helpful or technology can be helpful is in creating really granular data. If you accept that a rising tide does not lift all boats, and if you accept that generic solutions actually worsen disparities and disadvantage specific communities, data can inform you about who your populations are, and you can be proactive about intervening in ways that ensure that certain populations don't worsen disparities. And I think that's particularly important for people who are leaders in their businesses, people who are creating startups. If you think that, well, if we do this for everybody, it's going to work the same, you're wrong. We know this already.
If I might just comment on that, I think you nailed it. So we know that there's something called the Amenability Factor. Who gets access to technology that makes a difference first, their lives are better, and so technology can actually increase disparity. It was first recognized when the British, the wife of the British ambassador to Turkey brought smallpox vaccination back to Great Britain in the 1400s. Before then, the princes and the paupers all died at the same rate. But it turned out that the nobility, the children of nobility, began to get vaccinated for smallpox, and you began to see the first life expectancy gaps in the world. We've seen this in this city, but across the United States with breast cancer mortality disparity, that black women and white women had the exact same mortality rates. And when we introduce screening and adjuvant chemotherapy and now precision therapies, those who are assigned to be exposed to situations where they don't have such easy access, we've seen a mortality gap grow. When you address it, you can see it narrow. Now, where data is incredibly important is within our own institutions of asking the question, who among us is thriving and not, and using that data to illuminate and drive change, whether it be at the level of our board, our faculties, our physicians, our nursing staff, who's making decisions, but especially at the level of the patients we're taking care of. And I would encourage everyone who has a company here or is doing this kind of work, figure out how are you looking at your own data of your own company so we're not perpetuating these historical injustices through inadvertent work.
What maybe I could, and you've touched upon a little bit, and if you want to butt in with your thoughts, please do, James. just to make this practical for members of the Matter community, I really appreciate this question, and you all just talked a little bit about this. What questions should innovators ask themselves to avoid perpetuating historical injustices in their products? Any other counsel or advice?
So I'll connect it to the previous question and then talk about innovators. So, from an organizational perspective, the data is absolutely critical for us to understand who is being differentially impacted by whatever it is. Ultimately, we want to improve patient outcomes, but it's the processes of hiring, promotion, development, the processes of who's engaged or not engaged in the organization. And so data is critical for that. The other piece that I'll mention is that as we start to build these algorithms to drive decision making within the organization, it's critical that we have a diverse test set, a diverse set of individuals analyzing the algorithm so that you don't exacerbate disparities, but also analyzing the decisions that are made after the outcome of whatever the logic is. And so we're working in both of those areas. And so from an innovator's perspective, to come back to your last point, I think it's necessary that you have a diverse set of people that think differently around the table to define the problem and analyze the data, because it's very easy for a homogeneous group to say we're good, but the literature shows that heterogeneous groups outperform homogeneous groups from a decision-making perspective. And so it's just good business to be inclusive in terms of how you define problems and set strategy and allocate resources and evaluate your work going forward.
So one of the great benefits of a community like Matter is this kind of convening of ideas and resources. Question here is, with so many great initiatives, how do we bridge the gaps to partner, share, and connect things that are working today? Reactions?
So I'll say Feeding America has been part of a lot of coalitions, which, I think we all have our perhaps different opinions about coalitions and whether they're effective or not. But so we've invested in coalitions that really are goal-focused and have strategies and kind of their theories of change of how we can work together. And also just knowing, we don't always have to be the leader. So when we look at partnership opportunities, it's saying, are we going to partner in this together? Are you going to lead the charge and we're going to support you and be a thought leader in that space? So it's also, from Feeding America's perspective, kind of knowing our space in that partnership, but knowing that, of course, this work cannot be done alone. And so having fresh voices. So there's a website that I run called hungerandhealth.org. And it's great to get folks from all walks of life, all across different industries, that contact me through that site to say, hey, I have an idea, or can I have a conversation with you? It's 30 minutes of my time, but from that it sparks sometimes great partnerships that grow into solutions, or just a continued awareness of the work that's going on outside of our walls.
So I have to ask this question so that I don't no one accuses me of being biased. There's several questions in here about partnerships between providers and payers, insurers, and so we have a couple clinicians on the panel, at least one person who worked for a payer, one who works for a payer. Could you comment a little bit, anybody on the panel, and what that could look like in the future to address social determinants of health and health equity?
Maybe I'll give a start. We don't have a healthcare system. I think we could all admit to this, very fragmented. And I think everybody's looking towards their bottom line largely, and how, and that leads you to make bad decisions about who you're going to include and not going to include. So when we talk about population health or these other things, we tend to be payer-centric and institutional-centric versus community and person-centric. And if we could, and so I don't know how we get over that mountain. So if you're on Medicaid, for example, which is one of the great things about the Affordable Care Act, is that Medicaid was expanded, so a lot more people have coverage, but people move back and forth between policies. So one year you could be on this one, and next year another one. Next year you're on an exchange. Next year you have a job and you're employed, and you don't necessarily have loyalty to one product or another, and so neither will the company necessarily. So I would like to see us within Westside. You and I were talking about the West Side, and say, can we be community-centric, person-centric, but payer and institutional agnostic about our work? because if we're not doing this collectively, because it requires investment, and it requires a lot of investment in time and money and human capital to do this work. But if we're not looking at health in that sort of collective way, we're never going to achieve it. My concern is that we're way too fragmented and competitive to actually achieve the larger social aim that we have of equity.
You know, in the interest of time, and there are so many questions in here that I'm going to suggest to Steve and team that perhaps we have a series here instead of one dialogue. Just so many angles and dimensions to address here, but I do want to be sensitive to time, and again, so many great questions here. I would try and do a recap, except I think we've just scratched the surface of what we need to do as a community, as a community of healthcare providers and community leaders. I'm going to ask one last question. We go down the line, and then we'll wrap it up. What one action would you all recommend to audience members here? What one action could we all take today, and maybe or in the near term, that could make an impact?
Okay, so not knowing who is in the room and what your roles are, I would say that you really take a hard look at where you have an opportunity to make some specific change, equitable change, wherever you have influence. I suspect that you have an opportunity either from a policy perspective or from a resource allocation perspective or from an operations perspective, depending on where your domains of influence are. But that we really support you do it yourself and support people and organizations that are actually fighting to create equitable practices that ultimately will lead to some long-term structural changes. So that's my one thing.
Thank you.
Mine is really to engage communities and engage lived experiences and the voices of those that you're working with, should it not be yourself. And from my own perspective, that comes from a place of very much action-oriented. It's a day-to-day kind of evolution, and also a lot of humility. So just knowing, for me, is like I had to check my privilege, understand where I had power and where I had opportunity to step forward and step back. And all of that, I think, is important in engaging communities. That's how we'll move forward.
So we're sitting in a tech incubator with a lot of entrepreneurs and people who are growing businesses or interested in engaging in other businesses in partnership. My only piece of advice would be to keep in mind that you get what you pay for and be very thoughtful about how you're spending your money, both with your partners. Do they represent your values, goals, and experiences? The way in which you productize and promote your products? Are you putting them in front of the people that you want at a price point that matters? Are you buying equity in the work that you're doing? I would not lead this up to the goodness in people's hearts. You guys have the ability, you have the power of the pocketbook, and use it. Align the incentives in ways that both get you the outcome you want and does so in a very equitable way using proactive data, reshaping your intervention along the way, and getting feedback from your customers, suppliers, and team.
Maybe I'll just end on this. If we're really interested in narrowing life expectancy gaps, the two big drivers for this in this country are poverty and education. And if you look at this, we did West Side surveys, went lots of listening groups, and you listen to what people said. They said, number one, we want jobs, we want support of local business, but the third thing they said, our kids are feeling hopeless, and we need to support our kids. So one big effort around West Side United is say, imagine if every high school kid on the West Side had a mentored experience that could lead to a job and apprenticeship. And we said, well, how many high school kids are on the West Side? 20,000. A lot of time when we've had these experiences with children and you provide them that sort of guidance and mentorship, back to the comment about residents, it's like everyone's in a bell-shaped curve. But many times what they're lacking is just a coach, a guide, a way to sort of see long distance. So I'll challenge every single business in this room, and people can email me, agree to take summer students. One Summer Chicago funds 32,000 students, and only 29,000 get city jobs because only 3,000 there's availability within private industry. And if everybody said we're going to take summer students here, it's coaching and mentoring, I think that would be a great step forward for those folks in this room.
On that note, I'd like to thank those of you who joined us virtually, those of you here in the room, and especially our panelists.
We met at Blue Cross, remember?
We'll see you all again soon. Thank you.